try to use and analyze the timeline of this story. I have no conflict of interest. Now, you know that ARDS is considered an inflammatory syndrome, an inflammatory process characterized by three phases from the morphological standpoint, and a very early and then a late proliferative and fibrotic phase that are all characterized by a number of biological markers. And if you review the literature, you will see that the first anti-inflammatory intervention that has been considered for all these three phases is corticosteroid. Because of this, the corticosteroids have been the target of clinical trials since the very beginning of the history of clinical trial in ARDS. And this is one of the first, published in 1987 in the New England Journal of Medicine. Gordon Bernard is the first author. This study included patients with severe ARDS, what we will call now severe ARDS, at the very beginning of the clinical scenario. And the study was a placebo versus intervention study, where the intervention was high dose of methylprednisolone, 30 milligram per kilogram of body weight, given in one shot over a period of 24 hours. And the study was negative. No difference in terms of survival, no difference in terms of reversing ARDS. Later on, the approach was completely changed. Was completely changed by a number of studies. This is the first one of those studies, Umberto Meduri. This is a single-center study who had a very small number of patients. Actually, this is a study that had more statistics than patients included into the study. It included patients based on complete different criteria than the previous study. ARDS, but after 7 days of mechanical ventilation with a very severe marker of injury, the lung injury score, with no evidence of untreated infection. So there was a shift in the paradigm of the study from an early intervention to a late intervention for an unresolving ARDS. And the study, in fact, was a placebo versus methylprednisolone, 2 milligram per kilogram of body weight for 14 days, followed by a de-escalating dosage. And the study was dramatically positive. And this introduced, for the first time, the concept for steroids in the non-resolving ARDS. Later on, 2006, the NIH ARDS network validated this approach in a larger study, multi-center, a study that included about 400 patients, controlled intervention. And again, the criteria, the paradigm was the same. Patients in a late phase of the ARDS that had to be on entry a PF lower than 200. And again, a placebo versus a single-dose methylprednisolone given for 2 milligrams per predicted body weight, then followed by 0.5 every 6 hours for 14 days, and then a clear de-escalating approach for a late-phase ARDS. Now, the study had a signal in favor of steroids very early on in terms of probability of being disconnected from the ventilator, no signal in terms of improvement in survival. Both signals disappeared later on during the study observation. So no difference in mortality. And the study showed that methylprednisolone was associated with increased ventilator-free days, an improvement in oxygenation, an improvement in compliance. But when started more than 2 weeks after the onset of ARDS, so 2 weeks after the onset of ARDS, there was an increased risk of death, and there was a significant increase for risk of neuromuscular weakness. What's going on? Okay. Of course, given the substantial number of randomized control trial, we have meta-analysis. And also here you can see some sort of confusion and not consistent evidence. This is the first meta-analysis published in 2008, published by the British Medical Journal, that concluded saying that there were no convincing treatment effect on steroids in patients with ARDS, that was not clear the optimal dose, the timing, and the duration of therapy. And there was a call of attention on performing meta-analysis on studies that have a small number of patients included. And you see here the list of most of the studies that were used for this meta-analysis. All share this study limitation. It's a very small sample size. Some of them, single-center study. But on the other hand, you have other meta-analysis. Umberto Meduri is the first author of this meta-analysis, published a few years later, that gave a substantial different message. Prolonged glucocorticoid has a significant reduction in markers for systemic inflammation, reduction in duration of mechanical ventilation, reduction in hospital mortality by 7% in mild and 11% in severe ARDS, and shorter time for resolving ARDS. So, confusion with results of randomized controlled trial, confusion in meta-analysis. As a matter of fact, guidelines suggest the use of steroids in the late phase of ARDS. As a matter of fact, this study in 2020, just a few weeks before the beginning of COVID, included patients at the acute onset of ARDS, so another change in the indication and the timing for the use of ARDS. Conventional treatment versus conventional treatment plus dexamethasone in this case, 20 milligram per day, day 1, day 5, 10 milligram per day, day 6 to 10. So no placebo study, another steroid, and another timing for giving the steroid, and was with a significant reduction in mortality. Then COVID arrived. And we have this paper published on the New England Journal of Medicine. Now, this study does not have the limitation of all the previous studies on ARDS that I presented to you. This is a very large randomized control study that, open label, included patients hospitalized with COVID-19, randomly assigned to receive dexamethasone 6 milligram once daily for up to 10 days versus usual care alone. And the study included all hospitalized patients and showed an effect, a positive effect in terms of reduction of need of ventilatory support, reduction of need of multi-organ support only in patients admitted to the ICU, only in patients who were receiving oxygen. When I got COVID, it was quite severe. I was treated with steroids because of this study. At the same time, another group provided another randomized controlled trial that was stopped early because of the publication the New England Journal of Medicine published data. The study essentially used the same algorithm in terms of patient selection and in terms of steroids administration, but interestingly concluded that although suggestive for a benefit of the use of steroids, the study was stopped early and there was no clear data to support a definitive conclusion. And here we are talking about months of difference for the same clinical approach for the same patients. An ARDS caused by a viral pneumonia that was quite consistent and homogeneous. For the first time in our history, we treated a disease and not a syndrome, because COVID-19 evolving to ARDS, as a matter of fact, could be classified as a disease, or better, as an endotype of ARDS. And at the same time, as experience was gained, as data were accumulated, Giacomo Grasselli published this interesting study on critical care, showing that the incidence on ventilator-acquired pneumonia was significantly higher in patients treated with steroids than in patients not treated with steroids. And I started to get worried with my treatment. So I got steroids. I should check for my pneumonia. So, and again, evolving and using the timeline, the meta-analyses that were published were still controversial. This is the first meta-analysis performed by the WHO organization. They show a benefit in the use of steroids in patients with COVID-19. This is a Cochrane meta-analysis performed few months later that concluded that perform a meta-analysis using ventilatory outcomes has a limited value. So if I have to start to answer the question, classical ARDS versus COVID-19 ARDS, what are the differences? Clinical outcome, same doubts for conventional ARDS versus COVID-19 ARDS. The study design, all contexts have study limitations. For ARDS, small sample size. For COVID, no placebo control group. And the major difference between the two is that with ARDS, we treated the phenotype. With COVID-19-induced ARDS, we treated an endotype. So we had all patients with viral pneumonia treated with steroids. With conventional ARDS, we had patients with viral pneumonia, bacterial pneumonia, trauma, whatever. But there are some biological aspects that I would like to propose to you while I conclude my presentation. This is a subset analysis of a study that we published on JAMA before COVID-19. It was a randomized controlled trial where we randomized ARDS patients to be treated with interferon. In the study was negative, so interferon did not improve survival. And most interestingly, the combination of interferon in patients receiving steroids was associated to an increased risk of mortality. And in this subset analysis, we showed the effect of the administration of interferon to modulate the CD73, that is the receptor that is involved in the regulation of all the sequence of events activated by interferon. And you know that interferon is crucial in the response to bacteria, but most importantly, to the response to virus infection. And in fact, this is a second study that shows that this interaction between interferon and CD73 is regulated by steroid. And there is a variability, a polymorphism in the gene regulating this interaction. So that in some cases, the CD73 becomes independent from the signal that arises from the use of steroid. And in this case, you have a reduction in interferon gamma and a reduction in IL-6. Vice versa, the other aspect of the polymorphism is associated to a complete different biological reaction to the administration of steroids. So let me conclude with the same words that my friend and colleague Giacomo Grasselli used a number of months ago presenting some data on the use of steroids in ARDS. Steroid ARDS are not for anyone, for everyone. The evidence are still inconclusive. There is a clear risk of adverse events. Infections is the most important one, but we should not forget about hyperglycemia, GI bleeding, and salt and water retention. There is probably a negative signal in terms of virus pneumonia associated to ARDS, and the selection of patients may be crucial in this. So not for everyone. We should probably target patients with high pro-inflammatory markers, with markers of fibrofibrillation, or question markers that need to be answered. Thank you very much.